we can detect it early, and we can detect it early by spiral CT scans. These tests have some issues in having many false positives, and it needs to be done by an experienced team. But for people who don't have lung cancer, who are at risk, these annual spiral CT scans can reduce lung cancer mortality in the United States by 20%. Our treatments have also gotten better, and they've gotten better because of understanding two principles in lung cancer as well as other cancers. The first is molecular changes in lung cancer. So we know that some people's lung cancers have very specific mutations, and we have pills that are specific for treating only that one molecular abnormality. And the third major advance is our understanding of the immune system. And we now have immune treatments that can help patients that have advanced lung cancer and make them live longer and better with fewer side effects.
The story of an ALK translocated lung cancer has become sort of canonical in that we have been able to identify a subset of cancer and bring a targeted agent to those patients. That story continues to be repeated in lung cancer. So we see how ROS mutated lung cancers, which clinically are a lot like ALK translocated lung cancers, but how we're able to use similar drugs to shut down these cancers and improve survival. The development of resistance is, I think, the next wave. We understand that we probably need rebiopsies. We understand that we need novel ways of overcoming these resistance mechanisms. So efforts at this include development of second and third generation tyrosine kinase inhibitors, incorporation of other targets that may be downstream, and even adding drugs like heat shock protein 9D inhibitors that may change protein folding, again, to sort of reset the clock and to develop treatment for these patients that may have slow resistance. Areas I think that we certainly have to improve upon in the next few years is defining those cancers in which there is not a single oncogenic driver. Cancer for many individuals is complex, particularly in lung cancer where patients have often been exposed to multiple carcinogens over many years. So there might not just be one driver. So how do we integrate targeted agents together to shut down multiple growth signals? Often these targeted agents have overlapping toxicities, and so the issue is, do we sequence different targeted agents? Can we combine them? But truly I think that's sort of our next frontier in treating lung cancer.
I think there have been, unfortunately, some mixed messages from some of the organizations that have recommended screening about the potential harms of lung cancer screening. And I think, unfortunately, one of the detriments of sending those mixed messages is that that becomes a harm in and of itself, in that primary care physicians may not feel as comfortable in discussing the risks and benefits of lung cancer screening when it becomes so complex. And I think patients may get the wrong idea that lung cancer screening is more harmful than it really is. And the bottom line is that it saves lives. Obviously, cost is an extraordinarily important part of any discussion of something that is a public health issue. It's important to put this into perspective, and I think you really need to think about the 160,000 men and women who die every year of lung cancer and the number of people who might be saved with lung cancer screening,